Max Dalloway from Miami.
It's almost like getting ready for a football game. And then the day before they call up, no, you're not playing today. You've been all excited to go out in the field. So here I am 24 hours later, and I appreciate those who showed up today. Before I really get started my talk, you're not going to hear anything about molecular biology. I know nothing about molecular biology. But I think my journey that I'm going to talk about shows that you just keep your eyes open and think about your patients. And there are a lot of easy things that you can do to make difference. And I hope at the end of this, you'll see, yeah, that's really true. So this is my journey. Next slide. I could talk about several other things, thinking, well, maybe they don't want to really hear about my career. So we can talk about travel. I love it. A lot of it's been through this great specialty of urology. But I guess we don't have time for travel or photography. Next slide. And if you like sports, next slide. I still play basketball. So if you come to Miami any Sunday morning, you'll get me and a bunch of 35-year-old guys right on the ocean, the Atlantic Ocean. Weather permitting, we play 4-on-4, and you're all welcome. Absolutely. You see a lot of young guys. You see I started in Memphis in the middle on the top there. On the bottom actually is a great one. Bob Fleischer is a 6'8" urologist who played for Duke University. And I've gotten to know him. He's a superb urologist, but it was amazing. He played 4 years of pro basketball. So one of these days, you get a chance, we can talk about him more. Next slide. So here's my journey, almost 50 years in urology. Next slide. So very briefly, I started out in Cleveland, Ohio, where I was born, and then had my fellowship with surgical oncology at the NCI. You're familiar with that. It was very important for me. Then I went on back to Cleveland for my residency, went to Elvis's hometown, Memphis, Tennessee, where I spent 15 years, the largest private hospital in the country at the time, one of the reasons I went there. And then on to chairmanship at the University of Miami, and then I moved in 2014 to a wonderful hospital system, still working full-time. Next slide. So, important message, and a lot of people here will have great stories, and there's a lot of serendipity, right place at the right time. Watch the masters, the people around you, and you've already heard that already from several people. Learn from your peers. Collaboration is critical, no question. You can't do this kind of stuff alone. And again, obviously, there's no substitute for hard work. Next. So, the fellow on your left, who was a neurosurgeon, I would never have done research going into medical school. I didn't know whether I wanted to be a medical doctor or surgical doctor. We had to do a thesis. This was one of the most important parts of my life. I could not graduate medical school without a research thesis. I don't think that goes on now. I was lucky to get into this man's laboratory. A very interesting gentleman, but at any rate, he was working on the isolated monkey brain. He had this concept that you eventually, someday, you could transplant the brain to another individual. Well, as part of that study, he had me do a project where I learned to clip the middle cerebral artery of dogs and then monkeys. And eventually, I was a published research. I could do surgery, technically difficult surgery, and I could publish. I said, wow, changed my life, no doubt about it. And then, of course, went into urology. I decided for a variety of reasons that was a great specialty. Next slide. I had amazing peers. Who you work with is really important. You see 3 of those people there went on to chairmanships of urology at major institutions. Those were the people I worked with during my urology residency in Cleveland. Next slide. And you have to have heroes. When I was midway during my residency, I met Willa Whitmore. Oh my God. How many of you know who Willa Whitmore is? Now, look at that. Very, very few. Very few. Even the people who go there now at the memorial, who's Willa Whitmore? He was my hero. Very charismatic, the father of urologic oncology in the U.S. Next slide. So I said I want to be with him. Now, Germany has an important part, actually, in my early career. I was over in Tokyo as a young guy, and I met this fellow from Hamburg, Germany, Max Bressel. Now the Germans all know him. Very stern guy. I was initially totally afraid to meet him. He looked like he was right out of the Gestapo. Those of you who know about it, seriously, he made me so nervous. But at any rate, he was very friendly after I got to meet him a little bit. We had a couple of days together before the meeting, and he invited me to Hamburg to watch his prostatectomy. He was one of the early prostatectomy adopters in Europe. And so that was my beginning, my relationship. By chance, I took German in high school. Now my kids, of course, fortunately took Spanish. I'm in Miami. I don't remember many of my German. I have to understand Spanish to some degree. Next slide. But Max was amazing. And there are a number of other German leaders. So I've been here probably more than anywhere, particularly in my early career. And my hat's off to all of these people. They're your peers. They're who you talk to, change ideas. Next slide. And here you see the father of Marcus, who was a good friend, and I went to Mike's very early in my career. Next slide. And here we have Richard. Richard I've known probably more than any other urologist outside of the States. We go back, I don't know how many years. 1985, I wanted to learn the neobladder. I came over to Ulm, watched them operate, went back, do one, watch one, do one, teach one, and then started doing this amazing operative procedure. And all my patients, I talked to them. That's where I began this procedure with Richard, great colleague. And of course, you see Stefan and Ali, his two kids who are physicians. Next slide. So, during my career, you can't do this alone. I've written about 600 articles, but guess what? Everyone involved, other people, fellows, residents. Next slide. Here are some of the fellows from around the world that I've had the great privilege of working with. Next slide. And some of the residents on your upper left, Vic Patel was a resident. Jeff Weeder is amazing, we'll tell you about him. He wrote a pocketbook of urology, started as his first year of urology resident taking notes, and almost every resident, I don't know, outside the States, has this pocketbook that Jeff Weeder wrote and keeps up with. Next slide. So take you back in time. I think it's important to move you back so you can see where I was when I first went to the NCI. Next slide. And again, the Bee Gees, one of them lives in Miami. I haven't met him yet, I want to. But it takes you back where I was in the 70s. Next slide. So the first project we'll talk about, improve the dismal cure for advanced bladder cancer. Next slide. So here I am in your upper left. Bill Catalona was in my group. There were 5 of us who were able to not go to Vietnam, but went to the National Cancer Institute, to the surgery branch, and that was a blessing. My life would totally be changed if it were not for that opportunity. Next slide. So we had to do a project there. So what was I going to do? And I thought about it during the beginning of my first year. You had to decide. So I had these volumes at home, and I started looking at it. Next slide. And here you see the state of the art for advanced bladder cancer in the 1970s. This is from Roswell Park. Next slide. Big cancer hospital. Look at the bottom. 80% of the people with locally advanced bladder cancer dead of bladder cancer. Very few, only 20%, were able to even have a cystectomy. Chemotherapy, only 5FU at that time. Next slide. Cornell, not much different. Look, stage C and D, 10% cure rate. Miserable. Next slide. And here's what they said at the end of the article. Dismal prognosis. Hope that new modalities such as chemo, maybe pre-op radiation will help. Next slide. At UCLA, they tried pre-op radiation therapy. Not much of an improvement. Next slide. So I'm sitting there, what kind of research can I do? And just, if you believe in a supreme being, the chance, I happen to see this article that you could give mice, rodents, this compound, and they're going to develop bladder cancer. I said, geez, there's no budget at the NCI, you can do what you want. It wasn't like today, you have to put in for it. So I said, give me some of that compound, I'll take care of the mice. Next slide. So what happened? Sure enough, you give it a high percent, and under the microscope, it looks identical to human urothelial carcinoma. So I had hundreds of mice running around these little crates, and they're developing bladder cancer. How do you know if a mouse has bladder cancer? you pick it up. If the urine is red, there you go. And I wrote an article. You can do urinary cytology on mice and you find out when they have cancer. All right, now what are you going to do? So I went over to the pharmacology section and I said, do you have any drugs that I can test with my mice? And they said, well, he's got this compound. We don't think it's ever going to make it to the clinic. It's called cysteamine dichloroplatinum 2. Nephrotoxic, it won't make it, but here's some files. So I took it and I worked on a dose that the mice could receive. Previous slide, just for a second. And sure enough, there you got the tumors. Next slide. And since they're all syngeneic mice, found out that you could give it to them, or you could take out the tumor and put it in the hind limb, and you can measure it periodically. So I can see if this drug would work. Next slide. Barnett Rosenberg, I think he should have got the Nobel Prize. Cisplatin for 45 years has been the main chemotherapy for many, many cancers, not only bladder cancer. Next slide. So here I am, it works. Incredible. You give this drug, the percentage of likelihood of cancer on those mice who got the drug was dramatically less. Almost every mouse that didn't get it had urothelial carcinoma. Next slide. And this is one of my very first slides. I showed it at the American College of Surgeons in the urology or surgical section. Next slide. And soon after, I took my mice back to Cleveland, and during my residency for 3 years in urology, I also ran a laboratory. So I had a technician. I was running back and forth between the operating room and then one hand taking care of people and taking care of the mice with various projects. Next slide. And then I met this fellow, Alan Yagoda. Probably very few of you know who he is, probably Peter, I think, and some people in the room. Amazing medical oncologist. And he was at Memorial. And he was at my talk when I talked about cisplatin. And he said, well, we're just beginning to think we can get around the nephrotoxicity with the mannitol-induced diuresis. I said, fantastic. Well, we tried on bladder cancer. It works in these mice. He said, all right. Next slide. So I went then, after my first academic job, after Cleveland, I went to the University of Tennessee in Memphis. None of the medical oncologists had any idea about cisplatin, but I did. I had it in the lab, and I was aware of what's going on. I talked to the people at Memorial and MD Anderson, so I'm going to give it myself. I had no choice. So I started giving it to my patients. Here I am, a young surgical urologic oncologist, but at the same time, we were going to give our own chemotherapy, which I did for a few years. Next slide. That was the first publication. This is when I had a few more patients, and again, far better than anything we had. This drug works, and you can safely give it. Next slide. And then I said, this is now in 1987, I said, look, if it works for locally advanced and metastatic, why not we give it before cystectomy? 16 years later, look how long it takes. The SWOG study proved that that exactly was correct, and it remains a guideline today. Next slide. Second project, can we improve the results of bladder preservation? So well, listen, again, no molecular biology here, folks. So I have all these mice, they've got tumors. So what I'm going to do, next slide, this is when I was in Memphis doing that. Next slide. In my mice, I'm going to give platinum and radiation at the same time compared to either alone. And sure enough, it was significantly better. Platinum is a adjunctive or a sensitizer to radiation therapy. That was my hypothesis. Next slide. So I have my mice, and indeed, that was the case. So this is the very first publication clinically. The first was the first research one on urothelial carcinoma in the animal, and it works. What works in the animal, Don Coffey always told me, it's very likely to work in the human. And here we have in our first response rate, dramatic results with a combination of platinum and external beam radiation therapy for patients not fit for cystectomy. Next slide. And then we did a not randomized trial, but a trial among people who couldn't get cystectomy with a multidisciplinary US group, and again, confirming that using platinum along with full dose external beam radiation therapy was better than either alone. Next slide. And that, of course, as you know, is also a current guideline. Next slide. Now what about the likelihood of patients getting another tumor after the first TUR? As you know, it's a dramatic likelihood of that occurring. Next slide. So why do people get subsequent tumors? All of you, of course, know that. Carcinogens, certainly from cigarette smoking, number one. Incomplete TUR, but what about implantation? Does that occur? Next slide. So in 1972, indicated in one of the publications in the journal, one of the most challenging features of, quote, superficial bladder cancer is a tendency to recur. Next slide. These I pulled out of this looks like the Dead Sea Scrolls to many of you. And of course it is. I found these original articles when I was planning for this talk. And so that might be cute to put up, but particularly look on the bottom right with this guy, and we all know this, but we don't think about it too often. Most primary tumors of the bladder are in the trigone, but over time you now start seeing tumors posterior, upper lateral wall. Why is that? What happens as a result of the TURBT that changes the location of tumors? Could it be implantation? So I had a way with my animal model to see if I could test that hypothesis. And I did this during my residency. Next slide. What I did is I say, how can I simulate a TUR of a bladder tumor in a mouse? Well, not so difficult. What you do is you take a little small catheter, you take female mice, you put a catheter in, you put a little electrode, and you touch the bladder wall, not to kill the mouse, not to perforate. You can learn to do that. And what am I going to do next? Well, very simple study. Again, it doesn't take molecular biology. Next slide. So what I did, I had 3 groups of mice. The one on the left, put in the tumor cells, but I don't touch the bladder wall. None of them got cancer. On the right side, cauterize the urothelium, of course no cancer. But if you do both, if you alter the surface of the bladder and you put in the tumor cells, 80%, you see on the right, have a big tumor there. So implantation in the animal is quite possible, and maybe it occurs in humans. So what can you do? You can't stop them from smoking, etc., but what can you do? You can put chemotherapy in the bladder and kill the cells. Next slide. Again, animal model to human. So we did that. At the top you see we did that in our animal model. Same model, but then put in mitomycin C and much less likelihood of a cancer. And therefore, I wrote an article in 1980. We only had Thiotepa before that, which provided myelosuppression, which wasn't optimal. And I said, this is the rationale for using intravesical chemotherapy to hopefully affect and reduce implantation. Next slide. And again, then I talked about mitomycin's use. Next slide. Many articles about that. Next slide, please. Again, finally, again, just like before, it took many years continuing to talk about intravesical chemotherapy, and finally, many years later, a prospective randomized trial in the UK showing that early intravesical chemotherapy reduces the likelihood of a subsequent tumor. And again, a third thing, which is now the current guideline. Next slide. And the MBT tumor still being used as of a few years ago. Next slide. It's been around for 40 years. So the next area I got excited about was the TURBT and endoscopy. Next slide. So I happened, again, Germany is important. I went up to visit Winter and eBay that made the Olympus endoscopes. I was amazed at this ability, the beautiful scopes that they made. Next slide. And that led to relationships with them, and then Ralph Klayman and myself were one of the first to have a flexible cystoscope in our hands in the United States. It was interesting, they were made in Japan, but the Japanese urologists never were the first to use them. We were, few of us in the States. And I took this to the AUA. When I first saw it started in patients, of course you couldn't see as perfectly well as with the rigid scope. But for the patient, oh my gosh, can you imagine? Most of you there, you realize, for all the young people there, for 40 years of urology, they were putting rigid scopes under local anesthesia into men, in their office all the time. Incredible. Would you ever want that done to you? Of course not. So when I looked at the flexible scope, I said, gee, this is a no-brainer. But at the AUA, when I presented it, people would come up, I can't see well, I'm never going to use that. When I went to the University of Miami, they were still only using rigid scopes. So I started in 85, 90 when I went to Miami, and I was the chairman now, and they're not using flexible scopes. I brought my flexible scope, Olympus obviously provided. And so what am I gonna do? I said, okay, you continue to use your rigid scopes, but as chairman, if they break, we're not getting them fixed. So after obviously a couple of years, everyone adapted to flexible cystoscopy. Next slide. And I've continued to use over the years. Dramatically, of course, we've really improved a lot on our rigid endoscopy. We now have the beautiful cameras. Next slide. However, I continue to say today, in fact, in this amazing conference here, we did not, as far as I know, have any talk on one of the most common operations of TURBT. Because we say, oh, that's a case you give to a junior resident. I maintain that a TURBT is a deceptively difficult operation in many of our patients. Of course, it's very easy with small little tumors, but once you get to heavy obese patients, anterior tumors, these can be very challenging. And there is very little literature on it. When you compare, and I've done this, go to PubMed, put in TURBT, put in radical prostatectomy, and you will find 10 times as many articles on radical prostatectomy technique as you will for bladder cancer and TURBT. Next slide. Again, we don't have tremendous guidelines on a TURBT, and as I'll mention to you, I disagree with some of them. Next slide. So one of the things that influenced me is we did a very simple analysis, and that is we took 70 patients that I had seen in my office's consultation within 4 weeks of a very good urologist doing a prior TURBT. And I just said, how many of the times when I looked in the bladder, I saw an obvious tumor? Now these guys weren't bad urologists, but 70% there was an incomplete resection. Of course, these are referrals, selected population. But what it means is that this is not a simple procedure. And so, okay, I'll take out the tumor, finish. Not so easy. Next slide. So therefore, just like when you get in the airplane, the pilots have amazing checklists, right? Or you don't take off. We don't have that in bladder cancer, but we're starting to. Next slide. So the very first article, David Pan, one of my fellows now in Australia, and I wrote this article on an exhaustive checklist that I think should be mandatory. It begins with pre-op all the way through post-op, but every detail of the surgical procedure should be annotated. And there are subsequent articles, Harry Herr from Memorial and others, one and a couple in Europe, show that if you do this, the likelihood of an excellent TURBT, certainly well documented, does occur. And I think it's a very important article we published 12 years ago. Next slide. The next is the management of low-grade TA tumors, already mentioned by Dr. Droll already and somewhat by Dr. Lerner. Next slide. So, this I feel also very strongly about. The initial tumor can be large, can be multiple, can be single. Next slide. For low-grade TA. But the subsequent tumors, which are very common, tend to be very small. Next slide. And that's important. Next slide. The treatment of low-grade TA tumors, however, I believe you should minimize the amount of treatment. Next slide. Now, the importance of grade in prognosis is not new at all. Next slide. We can go back to the 1970s. Here you see the progression rate to higher stage for low-grade TA is very, very low, less than 5%. Dying of bladder cancer approaches 0 in these patients. And that's been 50 years we know this information. Next slide. And here you bring it much more up to date by an article in Journal of Urology, 100-some patients. These patients rarely progress and not a single death from bladder cancer. That's amazing. Next slide. And not a surprise. Next slide. Can these patients safely be observed? Well, it seemed to me, look, you got a tumor that's basically a benign tumor. Why do you have to, every time you see a little subsequent tumor, why do you have to take them to the OR? Well, no one probably asked that question until I did. Next slide. So, in 2003, I had 32 patients in which I observed. And I said, Dr. Soloway, don't you have to take this out? I said, look, this tumor is not going to bother you. Let's just watch it for a while. And of course, the initial patients were elderly, you would like to avoid the operating room, anesthesia, etc. And I showed that not a single patient progressed to muscle-invasive bladder cancer, which was no surprise to me, maybe to others. And subsequently, there have been a dozen articles all confirming exactly what I said. Next slide. And here you have Professor Hurley in Italy has been a major proponent. They've got a big longitudinal study and consistently show that very rare, almost zero number of these patients will die of urothelial carcinoma or even progress, much less to T1, but almost never to T2. So it's basically, if you will, a benign active tumor. Next slide. So the point is, don't aggressively treat them. Either active surveillance, which is quite reasonable for many of them, or I believe, if possible, office cautery. What I found of interest, there are many parts of the world. In the US, just about every urologist has a flexible scope in the office. I believe the same in Canada. But in other parts of the world, Australia, New Zealand, they do not have flexible endoscopy in their office. Everybody goes into the hospital for a procedure. So therefore, in the States, we'll find a number of us will do office cautery. Obviously, next slide, there's a great benefit to this. It avoids the OR and anesthesia, time saving incredibly for the patient, and for us, it's a huge time saver. Next slide, please. And here's just a recent article that we did. Again, just patients of mine, monitoring them, either active surveillance, office cautery, and again, none of them progressed, and it was a very safe approach. Next slide. So what about our current guidelines, which still is the case now? And I have been doing my best to write several articles with various people trying to get this changed. Right now, our guidelines, both in Europe and from the AUA in the US, that the only low-risk tumor is a solitary, small, papillary, low-grade Ta tumor. Once the patient gets 2 or 3 tiny little tumors, they are now called intermediate risk. They are at no more risk of dying. Yes, they are at risk of a subsequent tumor as they get more, but not any risk in the progression, which is really the main thing in regard to alternative management strategies. So personally, next slide, I strongly would advocate, I'm only one person, I would love more people to, and I'm trying to do that, to say that all patients with low-grade TA should be in the low-risk category. That means for me, they shouldn't get BCG either. I don't think BCG works in this group of patients. Next slide. And getting back to, again, less treatment is better for the patient. If I present to you a 73-year-old man with hematuria, his very first tumor, and you're going to take him to the operating room, what operation? I've already asked several people at this meeting what they would do. And Professor Steckle up there, he and I had a conversation last evening, so the work goes on, we discussion, and he and I agree 100%. Many people think, and there's a recent article in the European Urology that says the guidelines should be obtaining in any initial TURBT, regardless of what it looks like, you obtain muscle in the specimen. To me, that doesn't make sense. Why do you dig a hole in the bladder when you have this tumor? Every urologist halfway through his training knows is a low-grade TA tumor. Maybe they're wrong, it could be high-grade TA, but this is not an invasive tumor. And Harry here goes back many years. Others, urologists, are very good at identifying a tumor just by looking at it. So to go into the increase your likelihood of complications, bleeding, recurrent TURs getting into the muscle makes no sense to me. Next slide. So that's the first question. So this is what I would do. Cold cup biopsy, there's no cautery artifact. You want to do an end block, a little bit into the lamina propria, that's fine. And then cauterize it. Next slide. And what about the same thing if you have a person with a long history of low-grade TA and you have multiple tumors, you want to take them to the OR, not do office cautery, that's fine. But again, I don't think you need a deep resection to take care of these tumors. Next slide, we can discuss that later. Very quickly, one other thing I'm very proud of. Next slide. So in the 1980s, I went over to Copenhagen and I found out about transrectal ultrasound, the Brulin Care machine. I met with this gentleman and I had one of the first ultrasound machines we brought to Memphis, Tennessee. Next slide. And then I began to do transrectal ultrasound biopsies. And for the young people here, for 10 years, doing transrectal ultrasound guided biopsy of the prostate, we did not use any anesthesia. I mean, when you think about it, it's like, were you crazy? So one day, John Obeck, who's in Istanbul, was my fellow, and we were doing it, and the patient's counting again, like they always do. How many biopsies are you gonna do? It's starting to hurt. I'm sweating. And we're saying, well, only a couple more. And I said to John, we are doing something wrong. You go to a dentist. First thing that dentist is gonna do, he puts a little cocaine on, then he infiltrates with local, and then he begins drilling your tooth. Otherwise, you would never go to that dentist. And here we are, punching holes in the prostate with no anesthesia. So John said to me, you know, there was a young guy in our recent little small meeting who talked about how to do anesthesia. I said, fine, now let's do it. So we got the spinal needle, we did the periprostatic nerve block, and thanks to Jay Gillenwater, I immediately wrote up 50 consecutive patients that there was no risk, and he immediately accepted the article. It was the first one in the Journal of Urology that year in 2000. So if there's anything I did that helped more people around the world, it was this periprostatic nerve block. It was one of the very first, if not the first study. And also a little side tech, when I presented the abstract at the AUA, someone from Johns Hopkins came up to me and said, Soloway, I respect you, but it doesn't work. I said, what do you mean it doesn't work? We've done it. Then we did a randomized trial, one side local, it works. He said, no, we tried it, it doesn't work. And I respected this guy a lot. So the next year he came up to me and he said, Mark, I apologize, we were doing it wrong. Next slide. I was an early enthusiast about active surveillance for prostate cancer, just to mention. Next slide. Next slide, please. And also, importance of every radiation oncologist should tell their patients who are getting radiation for prostate cancer that they are at risk of radiation-induced bladder cancer. I think we are now more aware of it. Radiation oncologists now are tending to tell the patients. I always tell patients, the risk is very small, but it's no question. Radiation therapy of the prostate can cause subsequent urothelial cancer. Next slide. Almost finished. And lastly, another thing, I always believe that we can learn from other subspecialties. You heard this the other day here about the robotics and gastrointestinal surgical. Next slide. This is one of the great surgeons who I met as a resident. He went on to do a fellowship in liver and kidney transplantation. And I said, Gaetano, I can learn from you. We should, when we do large open, and now it's developed into robotic, big surgical approaches for big tumors of the retroperitoneum. We should mobilize the liver, we should mobilize the spleen and pancreas, and we wrote about a dozen papers, and all the transplant people, many surgeons who work in this know Gaetano Chancho. Next slide, please. Next slide. You're finding my slides? Okay, no signal. Well, to finish, okay, if the slides don't come up, we're done with the academic part. The last couple slides I actually have as a patient. Why am I still doing urology? Why do I love urology? And it's actually a picture of me sitting in the office with patients. We have the privilege of meeting men and women, often over 60, 65 years old, who have, next slide. Thank you for coming up. This is the slide. So I just did this just recently as I left. Because every day I go to work, I'm going to meet someone with an interesting story. I gave you my story. I love talking to these people about their story, what they've been through. I've learned about every occupation there is, you name it. I can tell you a little bit, not a lot, of different occupations, people who fly airplanes, et cetera, and I think it's a great privilege to have that opportunity to take care of these people. Next slide. Just to mention, you can't do it without family. I'm proud that both of my kids, like Richard's, became physicians. If your family's not supportive, it's tough to be working all the time and traveling, etc. And the very last slide is to show you what I can look out the door at home. With all the world going on, trouble everywhere, you have the opportunity to look at nature and say there is something, you can meditate, sit there and say there are some good things in life. Thank you very, very much for your attention.